I think I first saw it in the CathSAP for ACC, but if you have ever seen the U.S. regional variations in PCI image, it's a graphic of the U.S. and it shows the wide range in the use of PCI. It's a fascinating image and one you probably still have in your head if you have seen that image. So we're moving here today to talk with Dr. Karen E. Joynt, MD, MPH, and she is with Cardiovascular Division of Brigham and Women's Hospital and VA Boston Healthcare System. It's a tale of two states, a comparison of PCI case mix in New York and Michigan. I love this. This is an NCDR analysis. First, I should say that at the top. And why did you pick these two states?
So there's been a lot of interest in understanding exactly why that variation exists in how much people use PCI. And one of the things that's gotten a lot of attention is public reporting. So New York is a state in which there's mandatory public reporting of outcomes after PCI, which means that every time you do a PCI, the outcome of that patient's admission, a death, for example, goes on a website that's accessible to the public. So there's been a lot of concern in the past, including some data to suggest that this is the case, that type of public reporting makes hospitals and providers risk averse. So it drops the rate of use of PCI, but not necessarily for the good reasons that you might think, but kind of because people are a little bit scared about their reporting. The flip side has been that public reporting may be an immensely powerful quality improvement tool. So if you know that people are watching, you're going to pay extra close attention and make sure that you do the right thing. So the question then is, can we find a state that we can compare sort of what the risk profile looks like and what the patients look like for a public reporting state, and then perhaps another state with a different quality improvement strategy? So Michigan, as a state, has a quality improvement strategy called continuous quality improvement, which is a partnership through Blue Cross Blue Shield, where hospitals get feedback on their performance. But the key difference is that is not publicly reported. So hospitals know their performance, they know where they fall along a continuum, but that's not broadcast to the public. So the idea is that perhaps that would maybe get around the risk aversion problem a little bit, but still incent improvement. So the point of this study was to look at patients in hospitals in those two states and try to understand whether the risk profile was different.
So what did the tale of these two states tell you? What story did they tell you?
Yeah, so I think the tale told a story that the patients receiving PCI in Michigan were sicker. So they had a higher rate of most of the comorbidities that we associate with worse outcomes for PCI, diabetes, et cetera. They also were more likely to have shown up in cardiogenic shock or cardiac arrest. And so suggesting that perhaps in Michigan, sicker patients are being taken to the cath lab, because of course what this database doesn't show you is the folks who don't go to the cath lab. So you assume that if the patients are sicker in Michigan, that's because the ones in New York are not sort of making it into your database. Right. So it did confirm that it looks like the Michigan patients were sicker. Now the mortality rate was also a little bit higher in Michigan than it was in New York by about 0.5%. Still very, very low rates of mortality overall, because many of these patients are stable outpatients. So we're looking at sort of just over versus under 1%.
If they're higher risk, one would assume that they might have a slightly higher mortality rate. So that's not a big surprise.
But that's exactly the point, is that even when you adjust for those things, you're still left with a slightly higher mortality rate.
Ah, okay.
The question is that because the models really can't ever fully take into account the differences in patients?
Right.
Or is that really because something about the public reporting pushes extra quality incentive so that the quality is actually better in the public reporting state? I think to get that kind of detail, it's going to take more of a qualitative approach to really kind of dig in on the way that people have responded on the ground to quality improvement. But I think it does tell us that it's really important to do these kind of studies, because these policies are going national, right? We're not moving away from transparency. No. We're moving toward transparency. And I think it's really important to see how these things play out. And so Tom Boyden, who's the first author of this paper, I think has done a terrific job in trying to take the first step toward understanding what really are the details and differences between two states with very different strategies.
And what do you think is the bottom line message from this particular paper? What do the experts learn from this?
I think the experts learn that public reporting probably does lead to risk aversion, but it may also lead to quality improvement above and beyond what just sort of internal reporting does itself. And the question is, how can we leverage the best of both worlds?
Absolutely.
So I think that's the tale of two cities, and hopefully the best of both worlds will be what we can report on at some event in the future.
That's really exciting. And again, this is using the NCDR database, correct?
Absolutely.
And for a look at this and other NCDR news items from the American Heart Association meeting, please check CardioSource World News. We're trying to cover a variety of different NCDR reports that were presented here. Some really good material this year. For CardioSource World News, I'm Rick McGuire.